Hello everyone. Today in this video we will be discussing about the urine examination. First we will discuss the indications of it. It detects many anatomical and functional abnormalities of the kidney and urinary tract, gives diagnosis information in diabetes mellitus, jaundice. Then we can do the culture of urine for the enteric fever or any other disease. Then bacteriological diagnosis of the urinary tract infection. So first, how is the urine collected? For the collection of urine for routine examination, we'll take a clean dry test tube and the midstream sample is preferred, and early morning sample is collected because it is the most concentrated one. For the quantitative examination, 24-hour sample collection is done. First we will have the physical examination, then we will have the chemical examination, and then the microscopic examination. In physical examination, we have to see the six main things are there. First we will see the volume. Normal volume is about 700 to 2500 ml, average is around 1200 ml. Now there are some terms which needs to be understood. Nocturia means urine passed excess of 500 ml during night. It is sign of an early renal failure. Polyuria means excess of urine passed in 24 hours, means more than 2500 ml. It can be due to physiological due to excess water intake, can be seasonal in the winter, or pathological due to diabetes mellitus or diabetes insipidus. Oliguria means less than 500 ml urine passed in 24 hours. It can be due to less intake of water, dehydration in summer, renal ischemia. Anuria means complete suppression of urine less than 100 ml in 24 hours. It can be due to any renal stones, tumors, renal ischemia, or any other thing which cause obstruction. Then we will see the color. Normal color is pale yellow due to pigments like urochrome, urobilinogen, uroerythrin, and uroporphyrin. Now different colors are there which indicate different things. First, colorless in diabetes mellitus, insipidus, or excess intake of water. Deep amber color due to good muscular exercise or high grade fever. Orange color due to increased urobilinogen or concentrated urine. Smoky urine due to small amount of blood administration of vitamin B12 or aniline dye. Red due to hematuria or hemoglobinuria. Yellow brown due to bile and its derivatives. Milky due to pus or fat. Green due to putrefied sample of phenol poisoning. Moving towards the odor, normally urine has a faint aromatic odor. If it is pungent, then it can be due to ammonia produced by bacterial contamination, putrid due to UTI, fruity in diabetic ketoacidosis, and mousy in phenylketonuria. Normal appearance is clear. Now we can see the reaction on the pH. It is slightly acidic. The pH range from the 4.6 to 8, average is around 6. Now if the urine is acidic, it can be due to high protein intake, example meat, ingestion of acidic fruit, respiratory and metabolic acidosis, UTI by E. coli. Alkaline urine is due to citrus fruits, vegetables, respiratory and metabolic alkalosis, and UTI by Proteus or Pseudomonas. The last thing is the specific gravity. Now what is it? It is the ratio of weight of 1 ml of urine to the weight of 1 ml distilled water. Normally it is around 1.003 to 1.030, usually around 1.015 to 1.025. Used to measure the concentrating and diluting power of the kidneys. It is increased in the morning and decreased in the afternoon. Conditions in which there is low specific gravity includes excess water intake or diabetes insipidus, and high specific gravity due to dehydration, albuminuria, or glycosuria. Moving towards the chemical examination, it is done for proteins, glucose, ketones, bile acid, bile salt, and blood. For protein, normal range is less than 150 mg per 24 hour, but in the condition we can say there is a proteinuria, means more than 150 mg per 24 hour of protein is secreted in the urine. Conditions for the proteinuria may be pre-renal, renal, or post-renal. Pre-renal is due to congestive heart failure, multiple myeloma. Renal may be due to nephrotic syndrome, glomerulonephritis. Post-renal may be due to tumors of ureter or bladder. First test done is heat acetic acid test. Principle is protein precipitate when boiled in acidic medium. Procedure is place 10 ml urine in a test tube. Heat the upper portion, lower one will be act as a control. Turbidity indicates phosphate or proteins. Now for the confirmation, add a few drops of 10% acetic acid. Turbidity of protein stay as it is, while phosphate will be decreased. Grading is there. If less than 0.1 gram per deciliter, so we can say the trace amount is there, a faint cloudiness. If there is no cloudiness, it means the test is negative. If the cloudiness without granularity is there, so 0.1 gram per deciliter will be there, so we can give the 1+ grading. So according to this, this is a grading table which we have to remember. Then the next is the sulfosalicylic acid test. Principle is the protein gets denatured by organic acid and forms a precipitate. Procedure is 3 ml of sulfosalicylic acid with 3 ml of urine. Cloudiness will appear at the junction of two, which will indicate the protein. This is a better confirmatory test than the heat acetic acid test. Now there is something known as a Benzon's protein test. Now what are the Benzon's protein? They are the monoclonal immunoglobulin light chains synthesized by the plasma cells. Now the causes in which Benson's proteins are seen in urine are multiple myeloma, primary amyloidosis, leukemias. In multiple myeloma, combined serum and urine electrophoresis is the procedure of choice. Now in the Benson's protein, the turbidity appears at 40 degrees Celsius and the precipitates are seen at 60 degrees Celsius. So if we are boiling at 100 degrees Celsius, there will be a clear appearance. But if we allow to cool it again, then the precipitate again appears. So we can confirm there is a Benson's protein in the urine. Now, what is microalbuminuria? Microalbuminuria means presence of albumin above normal level but below detectable range of conventional protein methods. 30 to 300 microgram of albumin per 24 hours is secreted in the urine. Then we can say that is a albuminuria. It is seen in diabetic and hypertension patient. Now, what is the significance? It is the earliest sign of renal damage in diabetes mellitus. Proteinuria may be heavy, moderate, or mild. It is more than 3.5 gram per day. It is heavy, moderate 1 to 3.5 gram per day. Mild is less than 1 gram per day. Heavy can be seen in nephrotic syndrome, diabetes mellitus. Moderate in multiple myeloma, glomerulonephritis. Mild can be seen in hypertension or fever. Second is for the glucose. Now normally there is no glucose present in the urine. Presence indicate diabetes mellitus, renal glycosuria, or endocrine disorder. Test is Benedict's test. Principle is cupric ions are reduced to cuprous ions by sugar when heated and color change appears. Procedure is 5 ml Benedict reagent in a test tube plus 0.5 or you can take 8 drops of urine, then boil for 5 minutes. Now the interpretation is if there is a blue color, there is a negative. We can take it as a control. If there is greenish blue color, traces are present. Green, yellow, orange and red indicates the presence of sugar in the urine. So according to that, the grading is given. Red is the most amount of sugar present in the urine. This is a semi-quantitative interpretation because on the basis of color we can identify how much amount of sugar is present in the urine. Now sucrose is not a reducing substance, so it will not give the test positive. The third is the ketone bodies. What are ketone bodies? They are the products of incomplete fat metabolism. 3 types are there: acetone, acetoacetic acid, and beta-hydroxybutyric acid. For ketosis is the term in blood and ketonuria for the urine. Causes are diabetic ketoacidosis, starvation and dehydration. The test is done Ruthera's test for acetone and acetoacetic acid. Principle is ketone bodies combined with alkaline solution of sodium nitroprusside forming purple ring. Procedure is take 5 ml urine in test tube, saturate with sodium ammonium sulfate, add few crystals of sodium nitroprusside salt 1 to 2 and shake. Add liquor ammonia from side of test tube. Appearance of purple permanganate color ring at junction indicates that the test is positive. This test is false positive in phenylketonuria. Fourth is the bile pigment. Causes of bilirubinuria are hepatocellular jaundice or obstructive jaundice. In hemolytic anemia, the bile pigment is absent in the urine. For that, the test done is the Fauchet test. Principle is when barium chloride added to urine, barium sulfate precipitate are formed. If bilirubin is present, it is absorbed on the precipitate. To this filter precipitate, Fauchet reagent containing FeCl2 added, which reduces bilirubin to biliverdin, so greenish blue color develops. Procedure is take 5 ml urine, add 2.5 ml of 10% barium chloride and mix. Filter it and obtain precipitate on filter paper. 1 drop of Fauchet reagent on the filter paper, blue-green color positive. So we can say that the bile pigments are present. Bile salts are free bile acid plus glycine or taurine. Now free bile acids are cholic acid, deoxycholic acid, quinodeoxycholic acid or lithocholic acid. Causes of bile salt in urine may be due to obstructive or hepatocellular jaundice. For that, the test is Hayes sulfur flower test. Principle is bile salt lowers surface tension of urine and sulfur powder sinks to the bottom. Normally it does not sink to the bottom. So procedure is 5 ml of urine, sprinkle the sulfur powder. If it sinks to the bottom, test is positive. If it floats, the test is negative. For urobilinogen, normal small amount is present but increased in hemolytic and hepatocellular jaundice and negative in the obstructive jaundice. For blood in the urine, it may be due to hematuria or hemoglobinuria. Hematuria is detected by microscopic examination. Hemoglobinuria is detected by chemical test. Earlier, benzidine test was used, but now the reagent strip test is more preferred. The causes of it are hemolytic uremic syndrome, mismatched blood transfusion, paroxysmal nocturnal hemoglobinuria, G6PD deficiency following oxidant drugs, disseminated intravascular coagulation, black water fever in Plasmodium falciparum malaria. Now, for the microscopic examination, what can we see in the microscope? We can see the cells, cast, crystals, and other organism or tumor cells. Cells can be RBC, leukocyte, epithelial cells. Cast can be cellular cast, inclusion cast, or cast matrix. Crystal can be seen in alkaline urine as well as in acidic urine. Now, what are hyaline crystals? The hyaline cast, they are composed of TAM phosphor protein. 0 to 2 hyaline cast per low power fill is normal, seen in renal disease, dehydration, fever, congestive heart failure, or diuretic therapy. In which condition the following casts are seen? The red cell casts are seen in acute glomerulonephritis, IgA nephropathy, lupus nephritis, waxy cast in chronic renal failure, ESRD, fatty cast in nephrotic syndrome. Now the crystals seen in the alkaline urine are triple phosphate, appearance of coffee lead, amorphous phosphate. Now importance is they are heat acetic acid test soluble. Calcium carbonate dumbbell shape appearance, ammonium biurate appearance is thorn apple shape. Crystals seen in the acidic urine, uric acid crystal which dissolves on heating, amorphous US, and calcium oxalate envelope shape. So here we conclude our urine examination. Thank you for watching.